So very good evening everyone. Good evening everyone. Hope I am audible and visible. Let me know in the chat box if you can hear me well and see me well. Good evening everyone. Hope all of you are doing good. Let me know in the chat box if you can hear me well and you can see me well. So today we will be discussing psychiatry. We will be having a quick session for INI-CET revision. So exam is in few days. So we will be discussing quickly some important topics of psychiatry. So a very good evening everyone. Let me know in the chat box if you can hear me and see me well. So a very good evening. Right, so as I mentioned, today we will be discussing very quickly some important points in psychiatry, very important and relevant for your INI-CET exam, for your upcoming exam. So it will be a rapid fire kind of a session, it will be a quick session. So good evening, don't worry, keep your nerves. Good evening Bhargavi, good evening Dr. Saab. So as your name is, keep your nerves, keeping your nerves is very important, before, just few days before the exam. So it is very, very important that you hold on to your nerves. So don't worry, we'll discuss some important points. So let us begin this session. Right, so in this session what we'll be covering is, we'll cover some important symptoms, some important basics of psychiatry. We'll learn some important diagnosis. Good evening everyone, good evening. We'll also talk about a very important topic for your INI-CET exam, drugs and treatment. So this is very important. And lastly, again very important topic, if you've seen the latest questions, epidemiology holds a very important position in some of the questions. So we'll in the end, so I know this is a very crucial phase of the preparation. So it's very important if we discuss some important data so that you will be fresh when you'll be giving your exam. And of course in this session we'll talk about some FQs, that is future questions which you can expect in the exam. So again a very good evening everyone. Let us start with the session. So let us start with this question. A patient when discussed about happy events and sad events in his life. So you're discussing some good events and some negative events in the life of the patient. The patient is showing no changes in emotion. The patient is just looking like this. You're discussing happy events, sad events, but he's showing no changes in the emotion. So good evening. What is this symptom? Can anybody tell me what is this symptom we are discussing? So what is this symptom? Anybody? When there are no changes in emotion, you are giving stimulus, positive things you are discussing, negative things you are discussing, but he is showing no changes in emotion. This is in the affect. Please remember, this is something which you are observing. This is in the affect. So what is this? What is this abnormality of affect? Anyone? This is known as flat affect. This is known as flat affect or blunt affect. Again important. So patient is not showing any changes in emotion. Can anybody tell me? So this is flat affect. What is this phenomena? Can anybody tell me what is this phenomena? Without any stimulus, without any reason, the patient is showing rapid changes of emotion. Within few seconds, the patient starts laughing and then patient starts crying. Rapid and abrupt changes in the emotions. Can anybody tell me what is this phenomena known as? What is this rapid and abrupt changes of emotion known as? Anybody? This is known as labile affect. This is known as labile affect. So such questions are very important when you are interviewing a patient and some symptoms may be asked. Okay. So the answer for this question is flat affect. Now the next question is where it is seen. Where will you find flat affect? Anybody? Can anybody tell me where will you find flat affect? Flat affect is seen in very important condition. It is seen in schizophrenia. It is seen in schizophrenia. So this is a very, very important question related to abnormality of affect. Now if I ask you, where will you find labile affect? Where will you find labile affect? When the affect is changing without any reason, rapid and abrupt changes of emotion, where will you find labile affect? Can anybody tell me two important conditions where you may find labile affect? Anyone? Can anybody tell me where will you find labile affect? One is it is seen in mania. Very good. Yes, Bhargavi, it is mania. Any other condition in which you may find labile affect? Very good. Yes, in mania you can find this. It can also be seen in organic mental disorder. It can also be seen in organic mental disorder. So this is again very important question about abnormality of affect. Now let's talk about this question. a patient, you are interviewing a patient, very good Roja, yes. NB Mehta, yes. Mania was one condition, another was organic mental disorder. A patient says, I am John, I am a con, my friend is Sean, I want an iPhone, throw stone, it's dawn, clean the lawn, gone, 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 gone. So patient is saying so many things, and if you can identify, so can you find, can you tell me what is this symptom? Right. So now let me know in the chat box if I am audible and visible. Some internet glitch came in. So I think now I am audible and visible. So let me know in the chat box. Right. So what is this phenomena? So this is an abnormality under thought. So patient is speaking so many things, and again in the question it is not mentioned the patient is speaking these things very fast. And if you can see, if you can identify, can you identify? Yes. So can you identify any pattern? So can you see these thoughts are connected? So these thoughts are connected by rhyming. They are not making any sense, but they are connected by rhyming. So what is this symptom? Okay, so what is this symptom? Can anybody tell me what is this symptom known as? This symptom is known as, so what is this known as? It is flight of ideas. So this is flight of ideas. So as we have learned, flight of ideas in which the thoughts move very fast. One thought is followed by another very rapidly. Goal is not reached in flight of ideas. Okay, goal is not reached, but still the thoughts are connected. There is some connection between the thoughts. This connection is either by chance, it can be either by chance, or it can be by clang association, So this can be by clang association. Clang association means rhyming word. So as in this case, the thoughts are connected by rhyming. So this is flight of ideas. Very good. This is flight of ideas. Now can anybody tell me where it is seen? Where it is seen? Flight of ideas is seen in which condition? Anybody? So where will you find flight of ideas? Flight of ideas is seen in a very important condition. Where it is seen? It is seen in a very important condition. Very good, Dr. Joy. Yes, it is seen in very good mania. Now, again, so when you talk about mania, so I have given you a mnemonic for mania. The mnemonic is me, dig fast. So I have given you a mnemonic to remember the symptoms of mania. And what is this F here? This F here is flight of ideas. So one is yes, it is seen in mania. Now some other conditions. Can anybody tell me any other condition in which you may also find mania? Any other in which you may find flight of ideas other than mania? So please remember, again this is a old, this is a PYQ of PGI where they ask that flight of ideas seen in, one was mania, other conditions such as even in schizophrenia, and even in organic mental disorders, you may find mania. But of course flight of idea, but of course you have to choose one option, it is mania, but these can be seen. So if you have one question in which one of the options is flight of ideas seen in all of the above, then it is seen in all these conditions. Is it clear to everyone? Very good. Yes, yes Bansi, Pooja, yes, Bhargavi, yes, correct. Now, so another interesting question, this is in fact another question which you can expect, such questions may come. A psychiatrist asks a patient, what is your name? And the patient replies, Mukesh. So patient named him correctly. Then the patient says, what do you do? The patient says, Mukesh. Patient says, psychiatrist asks, where do you live? And the patient says, Mukesh. What is the name of your wife? Patient says, Mukesh. So what is this symptom? Can anybody tell me what is this symptom? Initially he said it correctly, but now you can see he is repeating the same thought again and again. In all the question he is repeating the same thought. So can anybody tell me what is this phenomena or what is this symptom known as? So what is this symptom known as? Anyone? This symptom is known as, again very important point, perseveration. This symptom is known as perseveration. So you can remember again, as I've discussed, you can remember it with this trick, 3 P's. One is P for perseveration. The thought persists. One thought is persisting beyond the point of relevance. So initially this thought that the name Mukesh, it was relevant. But now in all the other questions, he is answering it with the same answer. It has now become irrelevant. So one thought is persisting beyond the point of relevance. So this is perseveration. So you may be asked, a patient is answering all the questions of the psychiatry with the same answer. So this is perseveration. Again, a very, very important concept. This is perseveration. Second question is where it is seen. Second question is where will you find perseveration? Very good. So where will you find perseveration? Anyone? So where will you find? There are two important conditions in which you may find perseveration. Two conditions where you may find perseveration. So can anybody tell me any condition in which you may find perseveration? Anyone? Okay, good attempt, Kuldeep. Okay. Now please remember these two important conditions. One is again in organic mental disorders you may find perseveration, and even in schizophrenia. These are two important conditions in which you may find perseveration. Yes, very good, NB Mehta, very good. So again, perseveration is an important question. You may be asked the phenomena or you may be asked where it is seen, right? So again, important. Now let's talk about the next question. A male patient is admitted in hospital and he claims that his wife present is not his wife but a hospital staff, and continues to believe so despite being tried to convince otherwise. So a patient's wife came in to meet him and he is saying that you are not my wife. Everyone is trying to convince him, but he is convinced that she is not my wife. Very good. So this is a false fixed firm belief held with extraordinary conviction. It is a delusion. It is delusional misidentification syndrome. Very good. So what is this symptom? Yes, it is Capgras syndrome. Very good. This is Capgras syndrome, and again, as I have given you a simple trick to remember Capgras syndrome. Very good. Close person replaced by stranger. Very good. Yes, correct. Pooja, Bhargavi, NB Mehta. Very good. So close person, as in the name I have given you this trick. So close person replaced by stranger. Here the person is, believing that a close person, his wife, has been replaced by a stranger. Now another important syndrome under this misidentification syndrome is Fregoli syndrome. Fregoli syndrome. So what is Fregoli syndrome? Here it is the opposite. Here the person believes that a familiar person is imposing as a stranger. Here the person believes that a familiar person is imposing as a stranger. So another trick to remember, you can remember it like this. In Capgras syndrome, the person fights or argues with C for Capgras, C for close person. So here in this question he is arguing with the wife that you are not my wife. While in Fregoli syndrome, the person fights or argues with a stranger. Okay. This has also been asked previously names as well. So again an important concept, again important. Okay. So please remember this. Now let's come to this next question. A psychiatry resident asks a patient admitted in the ward to repeat numbers after him. So he is giving him some numbers and he is asking him to repeat those numbers. Initially he gave 2 numbers and now gradually he is increasing the number. So for example, you say 2, 7, he is asking the patient to repeat the number and now he is increasing the numbers. So what is this test which is being conducted by the patient? Again such questions are being asked. So what is this test which the psychiatrist is performing? He is performing some cognitive function. He is assessing some cognitive function. Very good. Yes. So the test he is conducting is digit repetition or digit span test. Very good. Digit repetition or digit span test. It has 2 components. One is digit forward test and the other is digit backward test. Okay, both are used, but if you have to choose out of one, you may say digit forward test is a better test. So what is it assessing? It is assessing attention. So a digit repetition test is used to assess attention. Now can anybody tell me for what do we use 100 minus 7 test? Can anybody tell me for what cognitive function or higher mental function do we use 100 minus 7 or serial 7 subtraction test? We tell the patient to keep on subtracting 7 out of 100. So what do we check by this? Very good. Yes, we assess. Very good. It is concentration. Very good. We assess concentration by this. Very good. Now, a psychiatry resident asks a patient what will he do? What will he do if he sees his neighbor's house on fire. What is being assessed? What is being assessed? So, he is asking, he is giving a hypothetical situation that suppose your neighbor's house catches fire. So, and he is asking, so what he will do? So, what is being assessed here? What is being assessed by asking such questions? So, we are trying to see that what the patient will do if such hypothetical situation is there. So, what are we checking? What are we checking? Abstract thinking is ability to form concept, okay, ability to form concept or understand hidden meaning. So, for abstract thinking we have different tests, we will talk about that. So, any other? So, I am asking, so we are discussing, what decision he will take. So, based on the circumstances, what decision a person will take. So, what are we trying to assess? We are trying to assess judgment of the patient. And what particular judgment are we assessing by giving a hypothetical question, by giving a test situation? So, which type of judgment are we checking? Very good. Yes, Pooja, we are checking judgment. What type of judgment? We are assessing test judgment. Okay, so judgment is basically ability to take a decision. So, based on all the circumstances, taking a decision, test judgment. So, we are assessing test judgment. What are the tests we do? Okay, so since you have discussed, you are saying abstract thinking. So, what are the tests usually we do for abstract thinking? Abstract thinking is ability to understand hidden meaning or to form concepts. So, can anybody tell me what test we do to check abstract thinking? One is simply we can ask proverbs. So, proverb testing. Okay, we give proverb to the patient, and so proverbs have a hidden meaning. So, we give proverb. Any other test? Any other test, can anybody tell me, used to check abstract thinking? Any other test we do to check abstract thinking? Anyone? There is one more test, important test. It is similarity testing. Similarity testing. We ask similarity between two objects. For example, we can ask similarity between a car and a plane. We can ask the patient similarity. Very good. Yes, Sri Lakshmi, very good. It is similarity testing. So, if a person is able to know the functional similarity, like both are modes of transportation, then we say that the abstract thinking is intact. But if the person is only able to tell structural similarity, for example, both are made up of metal, both have tires, if such structural similarity, we say abstract thinking is impaired. Or loss of abstract thinking is known as concrete. When abstract thinking is absent, it is known as concrete thinking. Concrete thinking, which may be seen in schizophrenia, Okay, so this is also about abstract thinking, right? So, is it clear to everyone? Very good. So, such questions are asked, So, please be careful for answering such questions. Now, let us see this question. A psychiatry resident asks a patient about his illness. He denies of being ill. So, patient is ill, family members have brought the patient, and you ask the patient, tell me about your illness. Patient says, no, I am having no illness. So, what is the grade of insight? So, what is the psychiatrist assessing? He is assessing insight. What is insight? Insight is awareness of the illness. Is the person aware of his or her illness? So, usually we say in neurosis, insight is present. In psychosis, we say insight is absent. Very good. So, in this case, he is completely denying. So, what is the grade? Very good, Rizwan, Bhargavi, Pooja, Shifali, Ashutosh, very good. So, all of you are correct. Yes, Dr. N.B. Mehta, very good. So, this is in fact an PYQ, it's a names PYQ. So, these are 5 grades. I will just briefly tell you. So, this is very good. This is grade 1, where the person is completely denying that I am not having any illness. Grade 2 is patient may say there is slight awareness, but then patient may deny at the same time. So, patient may say, yes, I think I am having some problem, then say no, I am not having any problem. This is grade 2. Grade 3 is when the patient is aware, yes, I am having some problems, but he attributes it to some external, some physical or some medical or onto some unknown factors. So patient says, yes, I am having some problems, there is some problem of my thought, but he is attributing it to some external, physical, medical or unknown factors. For example, patient may say, I am having this trouble because I have a lot of workload at my office. So he is attributing it to some external factors. Grade 4 is intellectual insight. As the name suggests, again there is insight, there is awareness of the illness. It is because of my irrational thoughts, my feelings, but patient does not do anything or does not change his behavior, okay, does not modify his behavior. So he does not take medications properly, does not go for therapy or anything which has been suggested. He does not do any change. There is no change in his behavior. And fifth or the highest level of grade of insight is true emotional insight, grade 5, where patient is aware of being ill and also now he is changing his behavior. He is now applying this knowledge to change his behavior. So he is also doing changes. He is taking medicines properly, going for therapy, doing other things which have been suggested. So this is the highest level of insight. So these are the grades of insight. Very good. Now next question, a 75-year-old female is having difficulty in doing activities of daily routine. She is also having visual hallucinations. There are bradykinesia and tremors are present and also Lewy body is found. Lewy body is found. What is the diagnosis? What is the diagnosis? So she is having difficulty in doing daily routine activities. Some cognitive impairment is there. Cognitive deficits are there. And the person is also having visual hallucinations and also there are now motor symptoms such as bradykinesia, tremor, and Lewy body is also fine. So yes, so this was a question in NEET PG, and even before that when we were discussing about NEET PG revision, we had discussed this question. So yes, if suppose they don't give Lewy body dementia in the option, then yes, it becomes Parkinson. But what will be the first diagnosis? Yes, it is dementia. First diagnosis which may come to our mind is Lewy body dementia. Lewy body dementia, yes, one of the close differential diagnosis of this question is is Parkinson's disease. Is Parkinson's disease. Now even in Parkinson's disease, patient may have dementia. It is one of the cause of subcortical dementia. Even Lewy bodies are also found in Parkinson's disease. Okay, so one of the close differential is Parkinson's disease. Now clinically we can differentiate clinically. So Lewy body dementia has three core features. One is there is fluctuating cognition, visual hallucination and motor features of Parkinsonism. Okay, now clinically we may differentiate. Now in Lewy body dementia usually cognitive symptoms would occur, and along with this motor symptoms may also occur or may occur thereafter, but cognitive symptom would usually occur in the initial presentation, while in Parkinson's disease motor symptoms would occur first, and thereafter cognitive deficit or cognitive symptoms would occur. And in fact there is at least 1 year gap between development of motor symptoms to development of cognitive symptoms. So clinically also we can differentiate. So dementia is a very important topic. So in fact now we say that the most common cause of dementia overall is Alzheimer's dementia, and second most overall cause of dementia is now Lewy body dementia. So again Lewy body dementia is a very important topic, okay, very important topic for your exam. Is it clear to everyone? Yes, good. So this is Lewy body dementia. A 70-year-old female diagnosed with Alzheimer's disease. So she is having Alzheimer's disease. Which neurotransmitter is reduced? So what is the neurotransmitter which is reduced? Anyone? So which neurotransmitter is reduced in this case? So one very important neurotransmitter which is reduced is, so there is decrease of acetylcholine. There is decrease of acetylcholine. Very good. Yes, Dr. Manisha, very good. Yes, so acetylcholine is reduced. Any neurotransmitter which is increased, very good, Dr. N.B. Shahu. Surya, very good. Any neurotransmitter which is increased? Can anybody tell me which is increased? So yes, decrease of acetylcholine. Any neurotransmitter which is increased? Yes, it is glutamate. It is glutamate. Okay, it is glutamate. Now pathologically in Alzheimer's, especially in Alzheimer's disease, pathologically, microscopically, what findings do we get? What findings do we get in a case of Alzheimer's disease? So pathologically, what findings do we get? What findings we get? Amyloid plaques. Amyloid plaques. Also you may get neurofibrillary tangles. Very good. A beta amyloid deposition, also known as neuritic plaques or senile plaques. So in fact in this one slide, so when we talk about the drugs, so we know that these two receptors are abnormal, so we will use drugs which will increase acetylcholine. We will use a drug which would be acting as an antagonist of a glutamate receptor, and also there is a new drug again which we have discussed also previously, especially for Alzheimer's dementia. We have discussed about this drug which helps in now clearing of these amyloid deposits. So we have one drug which can even clear these amyloid deposits. So here you can remember the mechanism of action of the drugs as well. So again very important. Very good. Yes, Parth. So these are some important neurotransmitters, again you should know. Okay, now so some drugs, so one is cholinesterase inhibitors. So for drugs for dementia, one is cholinesterase inhibitor. So the mechanism is, these are inhibitors of acetylcholine esterase enzyme. So acetylcholine is broken down into acetyl plus choline. So this is inhibited. So what will happen? There will be increase in acetylcholine. So name some cholinesterase inhibitors. Memantine, very good, is a drug. We will talk about that drug. So name some cholinesterase inhibitors. So these are some important drugs. Staccarin, again we know it is not used because it is hepatotoxic. It is hepatotoxic. Some other important drugs, commonly used drugs like donepezil, rivastigmine, galantamine. Okay, so these are some important cholinesterase inhibitors. Now second, also we have discussed that there is increase of glutamate, so we will use a drug memantine. What is the mechanism of action of memantine? Can anybody tell me? What is the mechanism of action of memantine? So we know that glutamate is increased, excessive glutamate is neurotoxic, it is an excitatory neurotransmitter. So we will use an antagonist. So one of the glutamate receptor is NMDA. So NMDA is a glutamate receptor, so we will use an NMDA antagonist. Okay, very good. Yes, very good. It is NMDA. Sri Lakshmi, Dr. NB, yes, very good. It is NMDA antagonist. Now please remember, in especially in INI-CET, many times they ask question on a drug. You may not know 2 or 3 options, but you may know the right answer. Okay, for example, they had asked this question in the last exam, which of the following statement is true about memantine? And one of the option was that it is an NMD antagonist. So we know it is an NMD antagonist, so that was the correct answer. Okay, so this is very good. Yes, Deepak, correct. Now let's talk about the new drug. What is the new drug that is being, so this is a new drug. So earlier we would say that we have only drugs which could only slow down the progress. But now this is one drug which is approved by FDA, which we see that may help in the treatment. Okay, so it is aducanumab. Aducanumab. Again, from the name you can see it is approved by FDA. Okay, so the name is telling you it is a monoclonal antibody. So it is a human IgG1 monoclonal antibody, and as the name is telling you, AD, it is used only for Alzheimer's disease. It is used only for Alzheimer's disease. It binds to the A beta deposits. It binds to the, very good, yes, it is a monoclonal antibody. It binds to the A beta deposit and it helps in the clearance. It helps in the clearance. In fact, more such drugs are now in the pipeline. They are in the trial phases, and maybe in future we will have more such drugs. Okay, so this is one drug which has been approved. Adu, can you remember the name? Yes, you can. Aducanumab. Okay, so this is the drug. Do we use, Can we use drugs such as antipsychotics, antidepressants? Can we use these drugs for dementia? Anyone? Can we use these drugs in patients with dementia? So can we use these drugs in patients with dementia? This has been asked previously as a question. So they had asked risperidone, which is an antipsychotic, is not used as an offline drug in which condition? So one option was dementia. So can we use antipsychotics, antidepressants in dementia? Of course not for treating the dementia symptoms, but yes, we know in patients with dementia there are also neuropsychiatric symptoms. Neuropsychiatric symptoms are there, okay, such as there may be symptoms like depression, anxiety, patients may have delusions, hallucinations. So yes, we can use these drugs. Very good. Yes, 64 Sondier is very good. Bhargavi, Dr. NB, very good. Yes. Now let's talk about the next question. A patient with history of fever since, so there is a history of fever since 5 days and symptoms of suspiciousness towards the neighbor, hearing voices of the neighbor when no one is around, and altered sensorium. What is the diagnosis? So there is sudden onset of symptoms. Sudden onset of symptoms. What is this symptom? Suggesting of delusion. He is hearing voices. These are suggestive of hallucination. Can anybody tell me what is the diagnosis in this case? What is the diagnosis? Again, a very important question. What is the diagnosis here? There is history of only 5 days. Please see the duration and also see the symptoms. Very important. Let's try to see. Schizophrenia usually say 6 months. DSM-5 it says 6 months, isn't it? ATPD, again good attempt, Rizwan. ATPD, acute transient psychotic disorder or acute psychosis. But is there any symptom which is not in favor of acute psychosis? Any symptom which is not in favor? There is delusions and hallucination, there is acute onset. Any symptom which is very good? Yes, lovely Dubey, very good, lovely answer. Yes, very good. Yes, so these are two close differentials. So I'm asking, yes. So altered sensorium is telling you something about consciousness. It is telling you something about consciousness, that consciousness is impaired. So symptoms like altered sensorium, clouding of consciousness, okay, or confusion, okay, patient may be disoriented. These are telling you that there is impairment of consciousness. Sudden onset of symptoms, there is impairment of consciousness. What you should think of? You should think of delirium. Very good. You should think of delirium. Very good. Yes, Parth. So it is in fact the most common organic mental disorder. When we discuss organic mental disorder, we talk about delirium, dementia and amnestic disorder. So delirium. Very good. So is it clear to everyone? Please look at this. Please look at this. Again, it is suggesting it is delirium, right? Now, so now I have removed this. Now the symptoms are fever is there and there is symptoms of delusions and hallucination. Now what will be the diagnosis? Now what will be the diagnosis? So again, these are two close differentials. Again, don't get confused. A very important concept. Please remember this. So now what will be the diagnosis? Now most of you have answered that answer correctly. So please remember, now the diagnosis is acute psychosis or acute psychotic disorder. Please remember, fever may be present. In fact, fever may be there as a precipitating event. So fever may be there, or there may be some stressors such as there is some death of family members, some financial issues. So there may be some stressor may be there with acute psychosis, including fever. So please remember, now it is acute psychosis. Okay, so the differentiating is see the consciousness. Okay, again because both of them may have very similar presentation. Right, very good, Dr. Richapal, very good. Yes, Parth. Is it clear to everyone? Now this point has been asked numerous times in different ways. So hallucinations more commonly associated with organic mental disorders, or now we know them as neurocognitive disorders, both in DSM-5 and ICD-11. So what are so this question has been multiple times asked, which of the following is suggestive of organic mental disorders or neurocognitive disorders? So which hallucination? This is again very important. Many times they have twisted question language to ask this point. Which hallucination? So hallucination we know are false perception without any real object. 5 common important types of hallucination we know. So anybody? Is it auditory or any other answer? Okay. Which is more suggestive of organicity? Again, very important, this concept is very important. Yes, very good. It is visual hallucinations. Very good. It is visual hallucinations. So please remember this point again. Very good. Yes, Shri Lakshmi, Bhargavi, Deepak, Rakesh, Pooja, Dr. NB, very good. It is visual hallucination. So this point has been asked numerous times in different ways. So please remember this. This is so I've just put it as a one-liner so that you remember. If in any question, you know, of course, hallucinations, visual hallucination can be seen in disorders like schizophrenia. But you know, when you see visual hallucination, try to see if they're talking about organic disorders. A patient with symptoms since 10 years, he says that aliens are communicating and asking him to kill his distant relatives. He is suspicious that people want to kill him. Has decreased interest, decreased motivation. Also, he has stopped going to work. His self-care has deteriorated. What is the diagnosis of this case, of this question? So, what is the diagnosis? Please look at the symptom. First is duration. 10 years history you are getting. 10 years, you know, symptoms are there. He says the aliens are communicating and they are asking him to kill us. So, you know, some component of hallucination seems to be there. So, hallucinations. So, hallucination. And he is also suspicious that people want to kill him. So, he is suspicious. So, he is, you know, having these false beliefs. So, there is delusions also present. There is delusions also present. Very good. Yes, Bhargavi, very good. So, what is this symptom? There is decreased interest, decreased motivation. There is anhedonia. There is amotivation. What type of symptoms are these? These are negative symptoms. These are negative symptoms. Yes. So, what is the right diagnosis? Correct diagnosis. Very good, lovely Pooja, Bhargavi, Parth, very good. Right. So, this is, yes, this is negative symptom. So, the right answer is yes, it is schizophrenia. It is schizophrenia. Very good. Please see what is happening. He stopped going to work, self-care has deteriorated. Even there is functional impairment. His self-care, his social activities and occupational activities, they also decrease. So, there is functional impairment. So, again, you know, this functional impairment also helps us differentiate between schizophrenia and delusional disorders. In delusional disorders, first of all, of course, in delusional disorder, there is only delusion will be present as a symptom. Okay, and you know, other symptoms like hallucination, negative symptom will not be there. And one important point to differentiate, many times, you know, they give this in the question which helps to differentiate between schizophrenia and delusional disorder. Functioning. Usually functional impairment is not that much seen in delusional disorder. Okay, so very good. Yes, it is schizophrenia. A patient when asked what is his name, he repeat the same question. So, you ask the patient what is your name, he says what is your name, what do you do, what do you do, where do you live, where do you live. So, what is this symptom we are dealing with? So, what is the symptom we are dealing with? Again, very important, you know, this question was asked in some other exam. So, what is this phenomena? Anyone? Yes, this phenomena is echolalia. Very good. This is echo. Yes, Sri Lakshmi. This is echolalia. Yes, Bhargavi. This is echolalia. So, echo or echo is to repeat. Lalia means words. So, repeating words. What is echopraxia? Very good. Yes. Yes, Shahiriyar Islam. Very good. So, echopraxia, praxia means movement. Echopraxia will be repeating or mimicking examiner's movement. Whatever you are doing, the patient will also mimic your movements. You scratch your head, patient will also scratch his head. So, this is echopraxia. So, while the symptom in the question is echolalia. Very good. Echolalia is one of the catatonic symptoms. Now, what is this symptom? If you see in this image, again image based questions may be asked. So, patient is maintaining a very odd posture and he is maintaining this odd posture for a long time. So, he is maintaining this odd posture for a long time. So, what is this? So, what is this? Yes, very good. Yes, Rizwan, Deepak. Yes, this is very good. This is, it is either catalepsy. So, this is either, so patient is maintaining a odd posture or this is posturing. There is something known as, please remember, there is something known as cataplexy. Cataplexy, which is seen in narcolepsy, which is a sleep disorder. So this is catalepsy. So in narcolepsy you don't have catalepsy. Okay, narcolepsy you have cataplexy. Yes, so patient is maintaining an odd posture for a long time. It is either catalepsy or posturing. How to differentiate? Catalepsy is a passive phenomena. So if someone else made him, come into this posture and now he is maintaining this posture, then it is catalepsy. And if he by himself is having this posture and now maintaining it, then it is posturing. So both are catatonic symptoms. Very good. Yes, Bhargavi, very good. It is a passive phenomena. Correct. Now, so these are catatonic symptoms. Name some catatonic symptoms other than these, such as mutism, waxy flexibility, okay, mannerism, stereotypies, okay, negativism. So these are some catatonic symptoms. What is the treatment of catatonic symptoms? So patient is having catatonic symptom. What is the treatment? So how do you treat? So patient comes with catatonic symptoms. So what is the treatment of these catatonic symptoms? Very good. So how do you treat? What is the treatment? Treatment of catatonic symptom is first is lorazepam. Very good. So we have two first line treatment. One is lorazepam. Again, initially it is given, as parenteral route such as IV route, IM route. Later on we can also give. Very good. And also ECT. Very good. So this again you should know the treatment. Okay, you should know the treatment. Even ECT is also used if a patient, suppose a patient is having depression with suicidal thoughts. Even then ECT is the treatment. It's an emergency. Now please remember, even if they tell you that the patient is pregnant, she is having depression with suicidal thoughts, then also ECT will be the preferred option. So ECT can be given in pregnancy. Please remember this point. A lot of the time they are asking questions on pregnancy and psychiatric disorders. So again, ECT is also used in depression with suicidal thoughts. It's an emergency. Is it clear to everyone? Again, these questions are important. Now, some prognostic factors in schizophrenia. Now tell me, so let us just see some of these prognostic factors. Tell me abrupt onset. So if someone develops schizophrenia abruptly, within few days or weeks, if someone develops schizophrenia abrupt onset, is a good prognostic factor or is it a poor prognostic factor? It is a good prognostic factor. Very good. Early onset is a bad prognostic factor. Very good. Family history. Now we are discussing family history of, so someone has a family history of mood disorder, he is having schizophrenia with family history of, again it is a good prognostic factor. And presence of mood symptom, patient having schizophrenia and let us see he is also having depressive symptom. So it is again a good prognostic factor. Please remember, at times they try to confuse you with these. So this is again important. Family history and presence of mood symptoms is a good prognostic factor. Being married, anybody, someone who is married is a good prognostic factor? Yes, marriage is a good prognostic factor. And presence of a precipitating factor. So there was a precipitating factor, let us say there was a financial loss after which patient develops schizophrenia. Again, presence of a precipitating factor is a good prognostic. Very good. Yes, Deepak, Bhargavi, yes, Sri Lakshmi, Dr. NB, yes, all of you are correct. So these are some prognostic factor. Again, many a times they confuse you with this. Please remember these. Now next question, let's talk about some psychopharmacology. These are some very important topics which they are asking again and again. A patient with diagnosis of schizophrenia on antipsychotics, and mechanism of action of this antipsychotic is it is a D2 antagonist. It also blocks alpha, H and M receptors and it is causing corneal and lenticular deposits. What is the drug we are talking about? So first of all, this is telling you this is a D2 antagonist. So this is a first generation antipsychotic we are talking about. It has some other, blocking effect also. So it is blocking alpha. So there may be hypotension, muscarinic blockage. So there may be anticholinergic side effects. There may be H histaminic blockage is there. So there may be sedation. In fact, this is your old INI-CET question. And I am also telling you some ocular findings. So you may be given an ocular, image, ophthalmology image, and you may be asked. So there are deposits on cornea and lens. Which is the drug we are talking about? Good attempt. No, it is not. It's a first generation. Very good. It is first generation with corneal lenticular deposit and also has other, these blockages as side effects also. So what is the drug? This is again important. The drug we are talking about is chlorpromazine. The drug which we are talking about is chlorpromazine. Again, very important. So you can remember C for chlorpromazine, C for corneal and lenticular deposits. So this is chlorpromazine. So again we will be discussing some of these questions, very important. Is it clear to everyone? Now another question. So again, diagnosis is schizophrenia, antipsychotic drug is used. Again we are using a D2 antagonist. Now some important points, it can cause QTC interval prolongation, less likely to cause EPS, EPS is less, and it is also causing again an ocular finding, retinal pigmentation may occur. So now which drug are we talking about? So what is this drug we are talking about? Anyone? This is important. It is a first generation, again it is a first generation, very good. Yes, now it is, you are correct. Now it is thioridazine. Thioridazine. Again you can remember thioridazine R, it is causing retinal pigmentation. It is causing retinal pigmentation. Any second generation, one important second generation antipsychotic which also increases the QTC interval. Anyone? Any second generation antipsychotic? Any second, one important second generation antipsychotic prolonging the QTC interval? It is, very good, it is ziprasidone. It is ziprasidone. Very good. Okay, so please remember some of these points, very good. Yes, other drugs are also there, very good. Now let us talk about the next question. This is in fact very good, Shubham. Yes, so let us talk about this question. This is again a NEET PG question which came recently, the last exam. So just twisted, one point I have added. A patient with diagnosis of schizophrenia not responding to haloperidol and thioridazine. So two drugs you have tried, the patient is not responding. Drug A you have given, which has side effects of silaruria, there is hypersalivation, dyslipidemia and hyperglycemia. And the drug was stopped because WBC count was 2000 per deciliter. What is this drug A? Very good. So what is this drug? Very good. So we are talking about clozapine. So clozapine is used for treatment, very good. Yes, treatment resistant schizophrenia. Treatment resistant schizophrenia. It is a second generation antipsychotic, but it is D4 activity is much more than D2. So it has less, in fact one of the drugs with least EPS, Some more points about clozapine. So clozapine, it causes hypersalivation, sialorrhea as has been mentioned. Now, so some of the mechanisms is that it is B4 agonism, because of B4 agonism, alpha 2 antagonism, and also decreases swallowing. Okay, so there is decrease in the swallowing. Now one important question is, a patient on clozapine having hypersalivation, what is the first step which you will do? Very good. So patient reports that when I wake up, my pillow, my bed is soiled because of saliva. So one simple practical, before starting drugs like clonidine, amitriptyline, one simple practical method is, we tell the patient to put a towel over his pillow. So one of the simple practical method is, so this may be asked, so what will be the next step you may do? Okay, so this is one simple practical method, very good. Yes, Bhargav, very good. Now metabolic side effect, it is in fact one of the drugs which has maximum weight gain. Okay, now metabolic side effects occur because of blockage of which receptor? This again question has been asked in your last INI-CET exam. So blockage of which receptor metabolic side effects occur? So what is the receptor? Yes, such as there is weight gain, there is diabetes, there is hyperlipidemia. Okay, yes. Anybody, blockage of which receptor? 5-HT2C, antagonism. So antagonism of 5-HT2C causes metabolic side effect. Yes, seizures can also occur. In fact, we have discussed some important side effects, serious side effects like seizures, agranulocytosis, myocarditis. Now one question which I want you to ask, again we have been discussing, which anti-epileptic drug is contraindicated with clozapine? Person has developed seizure, you may think of starting anti-epileptic. Which drug is contraindicated with clozapine? Which anti-epileptic drug you should not give is contraindicated? So can anybody tell me what is the drug I am talking about? So the drug which we are discussing is clozapine. Sorry, the drug with clozapine is, what is the drug? It is very good, yes, it is carbamazepine. Very good. So carbamazepine causes bone marrow suppression, and we know with clozapine agranular sortilin occur, it's a lethal combination. So carbamazepine is contraindicated. Very good, Deepak. Dr. NB, Sri Lakshmi, yes, very good. Now this was the question, in fact, which was asked, which of the following is not correctly matched with the effect? Now, so D2 antagonism, reduction of positive symptoms. Okay, let's focus on the first A and C first, and 5-HT2A antagonism increases dopaminergic activity. We know first generation drug are D2 antagonist, second generation are D2 and 5-HT2A antagonist, isn't it? So let's try to understand. So D2 antagonism, we know dopamine is increased in mesolimbic pathway. So yes, D2 antagonism decreases positive symptoms, but it can also lead to side effects. So side effects such as extrapyramidal side effects occur because of blockage of dopamine in the nigrostriatal pathway. So this is a side effect which occurs because of D2 antagonism, and side effects such as amenorrhea, galactorrhea, decreased libido, it occurs because of prolactinemia, which occurs because of decrease of dopamine in the tuberoinfundibular pathway. So D2 antagonism causes these things. Okay. When we talk about 5-HT2A antagonism, it decreases negative symptoms. Also 5-HT2A antagonism, it increases dopamine. It increases dopamine in pathways such as nigrostriatal pathway. So there is less EPS. That is why we say that second generation antipsychotics have less EPS. Right? So now let's talk about this. So second option, the D2 antagonism, there is reduction of positive symptoms, it is correct. 5-HT2 antagonism increases dopaminergic activity, that is also correct, because of which it has less EPS. M1 antagonism has reduction of EPS, it is also correct. When you talk about EPS, we use drugs like anticholinergic drugs in many of those EPS. So anticholinergic drugs, so M1, so muscarinic antagonism, yes, reduction of EPS. Is this statement correct? 5-HT2 antagonism, weight gain? No. We have just discussed which antagonism, 5-HT2C antagonism causes weight gain. Okay, so this is the right answer. So such questions, be ready with such questions. Right. Now let's talk about this question. A patient diagnosed with schizophrenia started on 2 mg daily dose of risperidone, presented very good, yes, presented with upward gait palsy after the last dose, night dose. So patient has come with sudden contraction of the ocular muscle upward. Eyes are rolled upwards. What is the next step in the management? First of all, what is the symptom with which the patient has come to you? What is this symptom? This is acute dystonia. We would want to use something parenteral, again very distressing. So let me discuss some of the EPS again. These are very important. You may get questions on extrapyramidal symptoms. So one is acute dystonia. It is one of the earliest symptoms. Sudden contraction of muscles such as oculogyric crisis, there may be torticollis, there may be laryngospasm, and we use anticholinergic drugs parenterally such as promethazine. Very good. Yes, Neeraj, Sonu, Shruti, Dr. NB, very good, Sonu. Yes, this is acute dystonia. Drug-induced Parkinsonism, patient comes with tremors, rigidity, bradykinesia. So then what is the drugs we use? We use anticholinergic drugs, usually give orally, drugs like trihexyphenidyl. Okay. So yes, very good. Now some of the other EPS, akathisia. Akathisia is the most common EPS. Akathisia means restlessness. There is subjective restlessness, patient reports that I am feeling restless, and also objectively you will feel that he is appearing restless. He will not be able to stay still, he may be pacing around, he may be jumping from one leg to another. So there is akathisia. Drug of choice for akathisia is propranolol, beta blocker like propranolol. Tardive dyskinesia, tardive means long term. So long term use of antipsychotics may lead to some movements, lip smacking or chewing movements. Patient is chewing, trunk protrusion or coriform hand movements like these, they may occur. Treatment is, we use drugs like valbenazine, tetrabenazine. These are VMAT2 inhibitors, vesicular monoamine transporter 2 inhibitors. These are basically dopamine depleters. Okay, dopamine depleters. And last, very important, it's again very critical, neuroleptic malignant syndrome. Okay, malignant syndrome. Here the patient may have high fever, increased CPK levels, muscle rigidity, sweating, tachycardia. Patient may appear confused. Again, drug of choice is dantrolene, skeletal muscle relaxant dantrolene. And other drugs, dopamine agonists such as amantadine, bromocriptine may also be used. Again, very important. Please remember these EPS for your exams. This is again very important. So, clinical presentation of such conditions may be asked in the exam. Right. Now, a female patient develops symptoms after delivery. So, let us try to understand some symptoms related with the delivery. Okay. So, she reports of sadness, tearfulness and decreased sleep. Onset usually occurs within 3 to 5 days after delivery and symptoms are transient. Transient. What is this? What is this? What is the diagnosis here? Very good. Yes, this is postpartum blues. Do you require any treatment? Do you require any treatment for postpartum blues? Please remember, no specific treatment. No treatment. Supportive treatment, psychoeducation is enough. No specific treatment. Patient reports of sadness, guilt, anhedonia, suicidal thoughts. So, such symptoms patient is reporting after delivery. Now, very good, yes. So, now what will be the diagnosis? Now, the diagnosis will be, it is postpartum depression. Very good, and you would want to treat. We would treat it with drugs like SSRI and we also can do CBT. One drug which is approved only for this condition, that is postpartum depression is, so it was approved by the FDA, is brexanolone. It is a GABA-A modulator. Okay. Okay. So, this is now. So, questions on postpartum blues and depression have been asked. So, a patient after pregnancy seems to be irritable, has decreased sleep. She says that this baby is not mine. I have not delivered any baby. Or she says that she is hearing voices to kill the baby. So, she has developed delusions and hallucinations after delivery. So, what is this diagnosis? Again, very important. What is the diagnosis here? This is very good. This is postpartum psychosis. And again, you have to treat. You can add drugs like antipsychotics. Very good. Is it clear to everyone? This has not been asked. Again, this is important. So, drugs like antipsychotics may be added. So, this is again an important slide. Pregnancy and psychiatry. Again, many questions have been asked these days. Is it clear to everyone? Now, SSRI, SNRI in pregnancy. This question in fact was asked in INI-CET exam. Now, most of the drugs usually can be given. They are not teratogenic, except which drug, which SSRI is teratogenic? Anybody? Which SSRI is teratogenic? Which SSRI? There is one important drug. So, we have discussed, in fact, in our previous discussion we have discussed which drug. P for pregnancy, P for paroxetine. Paroxetine, it causes cardiovascular defects. It causes cardiovascular defect. Okay, so paroxetine should not be given. Okay, it's contraindicated in pregnancy. Now, suppose we give SSRIs and SNRI in pregnancy. What effect can occur on the baby, on the infant? So, teratogenic effect we know on the infant. We know is one drug which is teratogenic. What effect other drugs can cause? Very good, Shruti. Yes, it is paroxetine. What effect? This question was asked in your exam. So, especially in the third trimester. So, teratogenic effect usually occur in the first trimester. SSRI, SNRI are given in pregnancy. What effect can occur on the infant? One very consistently seen effect which may be seen, and many studies have shown that it may occur, is pulmonary hypertension. Pulmonary hypertension. If you choose one, then it is the answer. It can also, smaller studies have shown that it can cause other conditions can occur, such as ADHD, neurodevelopmental disorder, even autism. So, others, so it is unclear. So in, one the question which was asked in your INI-CET exam was there was no option of, just pulmonary hypertension as the answer. So there the answer was all of the above. So because smaller studies, some studies have shown, but one finding which you have to choose, it is pulmonary hypertension. Is it clear to everyone? Again, this is important. Okay, now next. So again an important question. So again an important question, see this question, which of the following is incorrect? So I have included some important points in this one single question. So you have to choose which is the following is incorrect. SSRI, SNRI can cause sexual dysfunction? Yes, they can cause. Bupropion, metazapine causes less sexual side effects? This is correct. And in fact, this question has been asked numerous times. A patient on antidepressant, SSRI, SNRI develop sexual dysfunction, which drug you will switch to? So drugs like bupropion, metazapine. Paroxetine should be avoided in pregnancy. This is also correct. We have just discussed. Very good. Bupropion is safe in comorbid bulimia nervosa. This is incorrect. In fact, it is contraindicated. Very good. Because, so very good Bhargavi, Dr. NB Sonu, very good, because one of the side effect is seizure, and conditions such as bulimia nervosa, because of electrolyte disturbances, they are at risk of developing seizure. So this is contraindicated. So very good, this question may be asked. Okay, is it clear to everyone? Now least useful in TCA toxicity. So we have been, this question has been there. A person has TCA, tricyclic antidepressant toxicity. So we know, what kind of symptoms can occur in TCA toxicity. So there are CNS symptoms such as seizures may occur, then CVS symptoms like QRS, there is increased widening of QRS complex, then even ANS symptoms, dry mouth, those can occur. Okay, so patient can also have coma. So we one option we know, this has been an old question, TCA toxicity treatment is we will use alkalization. So this is sodium bicarbonate. So I am saying which of the following is least useful in TCA toxicity. So tell me, would you use diazepam? Yes, we can use diazepam for seizures. Okay, we can use diazepam seizure. Lidocaine again can be used because of cardiac toxicity, cardiac arrhythmia, again it can be used. Hemodialysis have not very much role in the TCA toxicity. So least useful will be out of these hemodialysis. Is it clear to everyone? Yes. So this is slightly twist, we just twisted the question, such question again may be asked. Okay. So be prepared with such questions as well. Is it clear to everyone? 9. 30-year-old woman with symptoms of excessive talking, cheerfulness, decreased sleep, excessive spending since 10 days. So she is having manic symptoms. So there are symptoms of mania. And there is history of depression 6 months back, for which she is on antidepressant. So what will be the first step? Again, so patient has mania and there is a history of depression. For which she was started on antidepressant. So again we have discussed this. So when you are talking about treating mania, the first step would be we would stop antidepressant. So there are two options in which we can stop antidepressant. So what will you start? Now we have also discussed in mania we have 3 first line drugs. We have antipsychotics, lithium and valproate. Now in this situation, which you will prefer? Please remember, she is a 30-year-old female, reproductive age group female, as we have discussed, generally we avoid valproate because of PCOD. I am not saying it cannot be given, but if possible, if you have an option, you may avoid valproate. Please remember, I am not talking about teratogenicity. I am talking about in female in reproductive age group. Okay, so the answer here is stop antidepressant and start olanzapine. Very good, Dr. Yes, very good. Shruti, Shivani, Shefali, Bhargavi, very good. Yes, is it correct? Now, again let's come to pregnancy and mania. Again, this is very, very important. I have already talked to you 3 first line drugs we have. So if a patient is pregnant and she has mania, what is the drug of choice? Anyone? What is the drug of choice? The drug of choice would be antipsychotics. Drug of choice will be antipsychotics. Again, lithium. What does lithium cause? What is the teratogenic effect of lithium? This has also been asked. What is the teratogenic effect of lithium? It causes Epstein anomaly. Very good. Okay. So if antipsychotic is known, then you may choose lithium, but you should avoid valproate. What is the teratogenic effect of valproate? So Epstein anomaly is a cardiovascular defect. It causes neural tube defect. Valproate causes neural tube defect. Okay. So again, all these have been asked. Okay. Now please remember one mood stabilizer, lithium, valproate are mood stabilizer. One mood stabilizer, lamotrigine, which is basically used in depressive phase, not much used in manic phase, is less teratogenic. Less teratogenic. Okay, less teratogenic. This has been also asked, this concept has also been asked previously. Okay, so again pregnancy and, very good, yes, pregnancy and psychiatry. Now just some important points about these things again. So suppose a patient reports of episodes of sudden onset of anxiety, feeling of impending doom. What, so we're talking about some anxiety disorder, sudden onset of anxiety with fear of dying, feeling of impending doom. What diagnosis generally comes to your mind? What is this? It is panic disorder. It is panic disorder. Okay. So again this, in fact, NEET PG, last exam question was this. A patient reports of, very good, excessive worries, apprehensions. There are continuous worries are there. Patient is having worries, something bad may happen. Previously they had asked this question, someone is having overthinking. So excessive worries are there. So what is the diagnosis if person is having excessive worries, apprehensions, small thing the person is very worried about? Very good, it is GAD. Very good, it is GAD. And someone is having irrational fear of any object or any situation. So we have phobias. So three type of situational anxiety we have discussed. One is agoraphobia, very good, specific phobia and social phobia. Very good. So phobias. So again you should know these, some of these key points. Many a times simple questions may come like this. Very good. Is it clear to everyone? So woman is having sleep disturbances. She is worried that her parents may die in a car accident. So she is worried, there is excessive worries. The answer is GAD. Is it clear to everyone? Right. Let's talk about the next question. Now again such questions may come. Try to see a patient shaving his beard, taking a lot of time and trying to do it symmetrically on both the sides, so much so that he is getting a lot of cuts and bruises. What is the diagnosis here? What is the diagnosis here? Again interesting question. What is the diagnosis of this question? Anyone? What is the diagnosis in this question? So person is doing something and is trying to do it symmetrically, spending a lot of time. Very good. Yes, Dr. Ben, Shruti, Bhargavi, Dr. Athar, yes, Surili, yes, very good. Yes, so all of you are correct. Yes, it is OCD. A person is eating meal and he is cutting the pieces equally, taking, cutting equally, spending a lot of time. Again, it's not an eating disorder, it is again OCD. Obsession is a disorder of, anyone, under thought. Obsession is a disorder of, under which flow, content, form, possession. Obsession is a disorder of what? It is a disorder of possession of thought. Again, this has also been asked previously. Very good. The most common, again, some of the obsessions and compulsions. Which is the most common? You should know this list. Most common is contamination. Very good, Sonu. Yes, contamination. And second is pathological doubts. Okay, then others are also there like symmetry, aggression, sexual. Okay, again, these you should know, and there are many others as well. Which is the most common compulsion? Very good. Which is the most common compulsion? C for compulsion, C for checking, C for checking. And second is washing. Okay. Then others such as symmetry, counting. Okay, these are others. So you should know, you should know this. Very good. Correct. Now let's go to the next question. Treatment of OCD. Let's talk about treatment of OCD. Drug of choice. Very good. Drug of choice. Very good, Surila, very good. Drug of choice. What is the drug of choice for OCD? It is SSRIs are the drug of choice. Very good, SSRI. One TCA is also used, that is also first line drug, that is clomipramine. Very good, clomipramine. But you have to choose one, then it is SSRI because of less side effect. Augmenting agent, a drug which we may add to SSRI, clomipramine, to improve the effect. Act as an augmenting agent. Can you tell me any augmenting agent? This question has been asked twice in the INI-CET exam. Augmenting agent for OCD. It is antipsychotics such as risperidone, aripiprazole. Very good. So augmenting agents are drugs like antipsychotic. So one is drug of choice. What is the therapy of choice? What is the therapy of choice for OCD? Therapy of choice for OCD is we use CBT. Which CBT? In fact, ERP, exposure and response prevention. This question has also been asked previously multiple times. So if to choose ERP or CBT, CBT will be more specific. Is it clear to everyone? Very good. Yes, Chinmay, Sonu, very good. Treatment of choice. If I ask you treatment of choice, again combination of drugs and therapy is the treatment of choice. Very good. Yes, Yashasvi. Very good, Kishore. So is it clear? Again, these question OCD is a very important topic. Please remember. Now, let's talk about this next question. A female child with normal development till 5 months followed by hand wringing movements. So these are stereotypic movements. Microcephaly, ataxia. Poor social communication and repetitive behavior. This is telling you that this is a autism spectrum disorder. Female child. What is the diagnosis? Very good. Very good. This is very important, Rett syndrome. And one important point I will discuss which may come in your as an FQ in your exam. So it is autism spectrum disorder. Important gene is MECP2 gene on chromosome XP28, which has been linked with Rett syndrome. One important, very good, one important drug I am going to discuss which is recently approved, in March only, 10th of March it got approval. So this is one drug which is your future MCQ, may come in your next upcoming INI-CET exam. So what is the new drug? What is the new drug which is approved for this condition? Anyone? This is very important. Please remember this drug, trofenatide. This is a very important question for your upcoming exam. Trofenatide. The name is telling you it is a peptide. It is a peptide. It is a tripeptide. So what is trofenatide? It is a tripeptide of glycine, proline, glutamic acid. It is basically an analog of the amino terminal tripeptide of IGF. What is IGF? What is IGF? Insulin-like growth factor. Okay, insulin-like growth factor 1. It is a analog of the amino terminal tripeptide. Its brand name is Debut. You can remember Debut. It has anti-inflammatory properties. It stimulates synaptic maturation. It is right now used for children more than 2 years. So this is one very important drug. Please remember, this is a new drug, a prospective new question, a future question for your upcoming exam. Even INI-CET and even the upcoming NEET next exam. Is it clear to everyone? Please remember the name of this drug. Now, a patient of alcohol dependence with deranged LFTs come in withdrawal state with tremors, hallucination and altered sensorium. What is the diagnosis? So, person is coming in withdrawal state. Can you tell me the diagnosis? What is the diagnosis here? So, again now we are discussing some very important substance related questions for your exam. So, what is the diagnosis here? So, patient has withdrawals. This symptom will help you tell the diagnosis. What is this? Very good. This is delirium tremens. Very good. Delirium tremens, which may, up to 72 hours usually it occurs. It peaks, 2 hours, after the, stoppage of alcohol. Usually the peak is somewhere between 48 to 72 hours. But please remember, it can occur even early, even in one day it can occur. This question was asked twice in your AIIMS exam. Delirium tremens. One of the important risk factor of delirium, tremens is infections. Okay, please don't, if they have described this patient and they say that symptoms have developed in one day, don't say since it has developed in one day it cannot be delirium tremens. Look for consciousness. Consciousness is impaired, delirium has set in. It can occur even early. So don't, stick to the duration. Please see the symptoms. Also, risk factor, one of the risk factor is infections such as hepatitis, pancreatitis, and delirium occurs because of sudden, sudden stoppage, sudden withdrawal. One of the option in the AIIMS question was that delirium tremens occurs because of gradual withdrawal of alcohol. No, gradual withdrawal of alcohol will have very mild or no withdrawal symptoms. It usually occurs after sudden withdrawal. Yes, some of the triggers like it, this has been asked twice in AIIMS exam. Okay, very good. Second is treatment. Now, what is the treatment of this condition? Anyone? So, what is the treatment of this condition? How will you treat it? So, we know treatment of choice are benzodiazepines. Now, can anybody tell me any specific benzodiazepine you would want to choose and why? Why? Please see this. deranged LFT. This is a very important clue. This question has been asked multiple times. So the liver is compromised. So which drugs are safe in liver disease? So please remember, what are the liver okay drugs? Two important drugs we can use. One is, very good, one is, so short acting drugs like lorazepam, diazepam, chlordiazepoxide, these are long acting drugs, not useful for for liver disease. And O is oxazepam. Both of them have been asked in your exams. Very good. Yes, Shruti, Sonu, Deepak, Dr. NB, Dr. Reformer, very good. MS, Kishore, okay, Chinmay, Dr. Ben, okay. So is it clear to everyone? So please be prepared with such question. Now, mechanism of action of drugs in maintenance phase of alcohol dependence. Now these questions have been asked. They had asked a question on disulfiram. What is the mechanism of action of disulfiram? What is the mechanism? It is a aldehyde. It is a aldehyde dehydrogenase inhibitor, ALDH inhibitor. This question was asked, which of the following is not true about disulfiram? One of the option was it is alcohol dehydrogenase inhibitor. No, it is a aldehyde dehydrogenase inhibitor. It's a aversive agent. It's a aversive agent. Is it clear to everyone? Very good. Now usually we say if you have to start a patient on disulfiram, the time from the last alcohol intake to the start of disulfiram. So person was consuming alcohol, the time should be at least 12 hours. So at least 12 hours should be the time when he has taken the alcohol last. And if one stops disulfiram up to 2 weeks, person can have disulfiram ethanol alcohol reaction. Okay. So this is again important. Is it clear to everyone? So disulfiram alcohol reaction can occur up to 2 weeks after stopping disulfiram. Okay. So very good. Yes, so very good. Now, so two important anti-craving agents you should know. One is acamprosate. What is the mechanism of acamprosate? It is a NMDA antagonist. NMDA antagonist. It is a anti-craving agent, and the other is naltrexone. What is naltrexone? What is the mechanism of naltrexone? It is a opioid mu antagonist. Opioid mu antagonist, right? So again, these question, again you may not know other options, but you may know the right answer. So you should know these important mechanism of action of these drugs. Very good. A patient consumes alcohol daily and patient develops symptoms of global confusion, ataxia and other associated symptoms. So what is the diagnosis here? So patient is consuming, very good, yes. So patient is consuming alcohol and now he has produced symptoms of global confusion, ataxia. Let us say there is one more symptom of ophthalmoplegia. What is this condition we are talking about? We are talking about neurocognitive, alcohol-induced neurocognitive disorder. What is this? This is Wernicke's, very good. This is Wernicke's encephalopathy. Very good, encephalopathy. Okay. Wernicke's encephalopathy, and it occurs because of deficiency of vitamin B1, thiamine. Two questions on this, Wernicke's was asked in the last NEET PG exam, the exam which occurred just few months back. Two questions were asked. This is again important topic. Another neurocognitive disorder is Korsakoff syndrome. Korsakoff syndrome. What is the treatment? So what is the treatment? We have just discussed. There is deficiency. Now even in this, please remember, when we are talking about alcohol, even in this, along with benzodiazepines, we add thiamine. Please remember this also. In the withdrawal state also, along with benzodiazepine we give thiamine. And now when we are talking about treatment of Wernicke's, again treatment is thiamine. Treatment is thiamine. Now suppose, let me give you, let's twist this question. Let's add one more condition. Suppose a patient comes to you with Wernicke's, Korsakoff symptoms. Okay, patient comes, but there is no improvement with thiamine. This is again an FQ. Such questions they are asking. So now they say there is no improvement with thiamine. What will you do? So you have given adequate thiamine, but there is no improvement. So what now will you add? We have discussed this, in one of our previous discussion. Does anybody remember what will you do? What will you add? Now this may be because of alcoholic pellagra encephalopathy, okay, which may also mimic like Wernicke's or Korsakoff. So what will you add? You will add niacin. Very good, you will add niacin. So this is again an important MCQ. So suppose they give you a picture of Wernicke's, or they don't mention thymine in the option, or they say that after thymine there is no improvement, then what will you do? You will add niacin. Very good, so you will add niacin. Is it clear to everyone? This is again an FQ. Please remember, I'll talk about some more such questions which you can expect in your exam. A 20-year-old male with respiratory depression, meiosis, having opioid toxicity. So patient has come with opioid toxicity. What is the treatment? This has been asked multiple times. So opioid intoxication, will use an antagonist. Will use a short-acting antagonist. What is the drug? We'll use IV naloxone. Very good, we will use IV naloxone. This question has been asked multiple times, so please remember this. We will use IV naloxone. Is it clear to everyone? Right. A 20-year-old male with symptoms of abdominal pain, yawning, diarrhea, rhinorrhea, sweating, lacrimation. Again, what substance, what withdrawal symptoms are these? Again, so you should know, pain in various conditions, leaking of body outlets we have discussed, like diarrhea, rhinorrhea, sweating, lacrimation, yawning. Then there is pupillary dilatation, okay, all these are, then there is, again, so all the piloerection, all these are symptoms of opioid withdrawal, okay, opioid withdrawal. There is pupillary dilation, okay, opioid withdrawal. Is it clear to everyone? Again, an opioid is an important topic. Now this, again an interesting question, please have a look at this question. A patient with acute intake of a substance, so he is taken a substance recently, complain of euphoria, there is cheerfulness, there is sense of time distortion, conjunctival reddening, the eyes are red conjunctiva. He is reporting of increased appetite, dry mouth, impaired motor coordination, mild tachycardia, hypotension. What is this substance? Again important, please remember this, such questions may be asked. Yes, this is cannabis. Very good, this is cannabis. Okay, please remember, cannabis can also have physical withdrawals. Earlier you used to believe that in cannabis physical dependence is not there, but physical withdrawal symptoms are seen. This condition is of the intake I am talking about. In withdrawal there are physical withdrawal symptoms like tremors, pain, chills, these are seen with cannabis. Very good, this is Sonu Kishore, Dr. N.B. Shivani, very good. A patient with intake of substance with tachycardia, hypertension, tachypnea and scratch marks. What is the substance we are dealing with? So patient comes to you with these symptoms. Very good, MS, yes, irritability seen in cannabis, withdrawal, very good. So what is this? What is the symptoms? So it's a stimulant. It is causing sympathetic activities increased, and scratch marks is telling you that he is scratching, there is some sensation. Yes, this is because of tactile hallucination, cocaine bugs. So what is the stimulant we are talking about? Very good, it is cocaine. Very good. Is it clear? So it's a stimulant. It is stimulant. Very good. Most efficacious drug in smoking cessation. Most efficacious drug in smoking cessation. Now please remember, let's talk about these drugs. One is NRT. So we have nicotine replacement therapy in the forms of gums, lozenges, there are patches, then there are spray, there is inhalers. Varenicline, what is? Yes, varenicline is the most efficacious. It is a partial, very good, it is a partial agonist of alpha 4 beta 2 nicotinic acetylcholine receptor. So it's a partial agonist at alpha 4 beta 2, 4 is coming first, alpha 4 beta 2 and acetylcholine receptor. It is an anti-craving agent. Anti-craving agent. Another anti-craving agent is bupropion. It is a NDRI. Now suppose they ask you a question, a patient is having depression and is also smoking, and he is also worried about sexual side effects of antidepressant. So depression, patient is also smoking and is also worried about sexual side effects of antidepressant. Which drug you may prefer in this condition? Anyone, which drug will you prefer in this condition? What is the drug which you will prefer in this condition? So please see, it's so smoking cessation, we know we can use drugs such as bupropion. which has less sexual side effect, it is also an antidepressant. In this case, maybe choosing bupropion may be a good option. Is it clear to everyone? Yes, such combinations may be also asked. Very good. A male patient with history of marital conflicts complains of early ejaculation. So, there is premature ejaculation. So, again such non-pharmacological methods have been asked again commonly. So, what are the two important non-pharmacological treatment for premature ejaculation? One is squeeze technique, and the other is stop start technique. Okay, squeeze technique and stop start technique, right? Is it clear to everyone? Right, great. For ED, for erectile dysfunction, we use sensate focus exercises. Again, these non-pharmacological methods have been asked again and again. So, in such clinical forms they may ask. Next, again simple question, EEG finding of a sleep state is given. If you see, look at this, what is this? This is, so there is outburst of waves, 11 to 16 hertz such frequency waves. These are sleep spindles. And what is this finding? Sharp, sharp waves, positive and negative waves. These are K complexes. So, what is this sleep state? So, we know it is seen in which stage of NREM. So, two findings in EEG. What is the stage? N2. Very good. The stage is N2. Two findings in EEG. It is N2. What is in REM? Again important. What is seen in REM? In REM, what type of waves we see? Again very important. So, we see beta and alpha waves which occur like this. So, what is this? This is sawtooth appearance. Okay. This is sawtooth appearance. Very good. So, these are some image based question. Now, question on anorexia nervosa eating disorder, few questions we will discuss. 16-year-old female admitted with diagnosis of anorexia nervosa, not gaining weight. So, you have given adequate calories, but she is not gaining weight. This is in fact a previous AIIMS question. After giving adequate calories, what is your next step? So, this is again important. So, usually we start patient with 1500 to 1800 kilocalorie per day, and gradually we increase to 3500 to 4000 kilocalorie per day. So, she is not, you have given it for a week, she is not showing any improvement. So, what will you do? Your next step will be, so what will be your next step? Your next step will be to observe the patient for, very good, for 2 hours after each meal, because she may be doing self-induced vomiting because of that, because even in anorexia nervosa we have binge eating purging type. Very good. Now, this is the next question which may occur. This is a newer question. A female, so please have a look, diagnosed with anorexia nervosa, after given food develop symptoms of low phosphate, low magnesium, low potassium, thiamine deficiency, and also develop cardiac arrhythmias. What is the diagnosis? This is important even in your surgery. This has been added in some of the newer updates. So, what is this? So, after feeding, because the patient was not eating food and suddenly you are giving calories, there may be increased metabolic rate. So, what is this phenomena? Very good. Very good, Sonu. This is refeeding syndrome. That is why we go very, slowly we increase the calories. Very good. This is refeeding syndrome. So, please remember these electrolyte, abnormalities with refeeding syndrome. Very good. So, this is again a very, very important concept. We will talk about some newer questions now, and we will talk about some epidemiology. Anorexia nervosa, 2 subtypes are there. We know restricting type and binge eating purging type. More common is restricting type. Please remember one important point which I am adding. So, these are some epidemiologies I will give you. So, very good to remember them just before your exams, because they may come very handy. Suicide rate seen in more in binge eating purging type than restricting type of anorexia nervosa. So, please just write these, some of these epidemiologies may be very useful for your exams. Is it clear to everyone? Now, again simple question, there is episodes of binge eating and purging, increase body weight, and there is a clinical sign. What is this? So if you see the callus, there is, there is on the knuckles, there is callus. So what is this sign known as? This is known as Russell sign. Okay, Russell sign. There is increased body weight. This is bulimia nervosa. This is bulimia nervosa. Again, electrolyte imbalance in bulimia nervosa. I want you to remember there is low potassium, there is hypochloremia, alkalosis. Because of repeated self-induced, vomiting, purging, the HCl is going out. So this can also be seen in anorexia nervosa. Which subtype? Binge eating, purging type. So this is it clear to everyone? One point you can add. So other than this, let me write here. So there is another eating disorder, binge eating disorder. Binge eating disorder, this is a new entity which has been added in DSM-5, binge eating disorder. So binge eating disorder, there is only binge eating, no purging, no compensatory behavior. One of the drug which is approved by the FDA for binge eating disorder, for short term treatment of binge eating disorder, the drug is, so the drug for binge eating disorder is lisdexamfetamine for short term treatment of binge eating disorder, lisdexamfetamine. So it is for short term treatment. Okay, short term treatment for binge eating disorder. Please remember this, binge eating disorder, there are only episodes of binge eating, no purging. Okay, is it clear to everyone? Right? Amenorrhea may be seen in anorexia nervosa, more in anorexia nervosa, sometimes even in bulimia also it can be seen. Okay, right. Now lithium, again a very important drug. Lithium, it's a mood stabilizer with anti-suicidal property. Antipsychotic with anti-suicidal property is clozapine. This question has been again asked recently. So it has a narrow therapeutic range, 0.5 to 1.5 milliequivalent. This was the question. Now acute mania, what is the range? It is 1 to 1.5 milliequivalent per liter, and for maintenance 0.6 to 1.2 milliequivalent per liter. Please remember this. Toxicity occurs when it is more than 1.5. Usually toxicity may occur in in dehydration, again, so body behaves, treats sodium like lithium like sodium. So whenever there is loss of sodium, body will try to reabsorb sodium, so it will also reabsorb lithium. It will lead to toxicity. Someone is fasting, there is dehydration, okay, there is a lot of vomiting again, so there may be lithium toxicity may develop, and hemodialysis may be required in severe cases of lithium toxicity. We have discussed these points. Now few important points, again, after how many days of start of lithium you would take the blood sample to know the lithium level. You have started the patient now, okay, you have started the patient now on lithium. After how many days will you take the sample? So basically after 5 days. So on the 6th day, steady state of steady state concentration occurs after 5 days. So after 5 days, on the 6th day you can take the sample, and when you take the sample, after how much time the last dose you will take the sample. This question was asked previously. So you will take the sample after 12 hours of the last dose. So you can also add plus minus 30 minutes. Okay, very good. Yes, Sonu, Dr. B, very good. So these are some important points. Again, tremors, lithium side effect. Tremors, what is the drug of choice for lithium induced tremors? It is propranolol. Just remember, even in akathisia we have discussed propranolol was the treatment, even in lithium induced tremors. Very good. Antimanic response of valproate, again a new question. So we give valproate. What dose in the blood generally has a will have the patient respond when what will be the blood level. So again, first you should remember the unit, microgram per ml. They may give different values, but you please remember the unit first. It is microgram per ml, and what is the range? 50 to 125. 50 to 125 microgram per ml. Again an important MCQ, right? Is it clear to everyone now? So now I will be talking about, so next questions will be epidemiology, a lot of questions on epidemiology. So what I will do is, I will try to give some important points to you which may be helpful in solving especially the INI-CET exam. So this part is again next 5-10 minutes are very important. So let us try to understand epidemiology. Schizophrenia, if we talk about prevalence more in males or females. So tell me in schizophrenia, good evening, Barad, good evening. So tell me it is more common in, so in schizophrenia we say it is, the prevalence is same in males and females. In depression In depression we say females more than males. In fact, this question was asked, as you know, they have tested which of the following is true. So one of the option was it is seen in more in adult females than males. So that was the right answer. Okay. Now in bipolar 1 disorder, it is same as schizophrenia. So same, male and female prevalence is same, and bipolar 2 again is same as depression, female more than male. So please remember these, very very important. Now let us talk about some other disorders. Depersonalization, derealization disorder. So here we say that it is again male is equal to females. So many of the dissociative disorders and somatic symptom and related disorder, many of those disorders we don't know the exact prevalence. Some of the important ones which we know I am discussing. Dissociative identity disorder, that is multiple personality disorder, conversion disorder. Here what is the prevalence? Again please remember, it is females more than males. Okay, females more than males. So this is again this question was asked in your exam. So if you seen the question, you know, the INI-CET question, so they may ask these data. So I am telling you some of the important ones here. Is it clear to everyone? Please remember them. You know, since we are very close to the exam, it will be very handy to remember. Again an important question. So let's see if you can answer this. All are common in females, more in females than male except. So I have taken all the anxiety disorders. So I have said all are more in females than males. So which one is not more in females? So what is the answer? Please remember, social anxiety disorder, male and female is nearly equal. So then again this can be put as an MCQ in different forms. So please remember these are important, especially for your INI-CET exam. Maybe just mention them, these last 5 minutes, very important, you know, especially for your upcoming exam. Please remember these. Now prevalence of personality disorder in general population. In general population we say it is around 10 to 20%. 10 to 20%. Many of them are common in, you know, males, some prevalence is not named. If we talk about borderline personality disorder, we say it is females more than males. Borderline personality disorder again is very important, you know, again very important. Please remember it is more in females than males, right? Is it clear to everyone? Now let us talk about some percentages. Now, so percentage of patient with schizophrenia who commit suicide. Okay, who commit suicide, what is the percentage? So what is the answer? It is 5 to 6%. Very very important. Please remember, percentage of patient with depression who commit suicide, it is again, it is all latest data, 10 to 15%. There may be 2/3 of patient with depression who may contemplate suicide, but who commit suicide, it is 10 to 15%. Most common cause of premature death in patients with schizophrenia, which is the single most common factor of premature death. Again very important, please remember it is suicide. It is suicide. Okay. And percentage of reversible causes of dementia, we know dementia usually is progressive, but some patients have reversible cause. 10 to 15% of the causes are reversible, such as vitamin B12 deficiency, hypothyroidism, again all are important. Hypothyroidism. Okay. So these are some important reversible causes. Is it clear to everyone? All these epidemiology data, you know, just for this session, you know, prepared so that it becomes very important for you. You can solve many questions. Mean age of onset of depression is around 40 years and mean age of onset of bipolar 1 disorder is 30 years. This question was asked in your recent exam, INI-CET exam. Which of the following statement is false about bipolar disorder? One statement was bipolar 1 disorder age of onset is 35 to 45 years. This is wrong. This is wrong. It is around 30 years and many even occur even early. Okay. So these are all epidemiology. Please write them down. Please remember some of these data. Lifetime prevalence of OCD in general population is 2 to 3%. 2 to 3%. Mean age of onset of OCD is 19 years. And onset may be, you know, early onset may be more in males. And when we talk about the prevalence, so the community studies, you know, have shown that it is females more than males. So females more than males. Is it clear to everyone? Please remember these important useful data, very very important. Now the last, you know, slide of the day. Most common comorbidity with agoraphobia. Can anybody tell me which is the most common comorbidity with agoraphobia? It is panic disorder. It is panic disorder. Which is the most common comorbidity means co means together, morbidity means illness. Which illness is also seen with these conditions? So with OCD, what is the most common comorbidity with OCD? This has been asked previously. This question has been asked previously. It is depression. It is very good, Bhargav. It is depression. You know, around 67% of the patient with OCD may also have depression. So very high. And anorexia nervosa, which is the most common comorbidity with anorexia nervosa. With anorexia nervosa also it is depression. Around 50% of the patient with anorexia nervosa may also have depression. So again, so these were the last few slides were of epidemiology, because we are seeing a lot of questions on epidemiology. So you should know some of these data which will help you solve some questions. Is it clear to everyone? Right. So this was about, you know, the session today. Now again, you know, exam in just few days, so I would say have faith in yourself, in your preparation. You know, don't worry. Our good wishes, you know, all the teachers from PrepLadder, every one of us, all our good wishes are with you, and we are sure you're going to rock the exam. So keep your nerves, you know, at the right place, you know, hold on to your nerves, and this will be very helpful. So, you know, all the very best. May you come out with flying colors. May God bless you always. Thank you everyone. Thank you everyone.